Good afternoon, everyone, or perhaps good morning, depending on where in the country you are viewing from today. My name is Erin Pellegrin. I am the Director of Culinary Nutrition and host of many of our digital education events. I am coming to you today for our second Ask the Experts for the month of January. So we've got a great topic. I will be giving this another minute or so for those to hop on to get viewing, but we've got a great discussion to be had this afternoon. As we wait for some viewers to hop on, let's go through a little bit of housekeeping. So just as a reminder, our Ask the Experts is our Q&A style digital education event. So we've got our most common questions about immunotherapy and your immune system happening. And as always, you are welcome to add your own comments and questions in the chat as we will be following along. So if you're watching on Facebook and you have questions or comments, feel free to chime on in. This will be housed in our Her library. So know that we are recording, and if you have to hop off early, or if you're not able to catch all of this, or if you have someone else that might be interested in listening about this topic, you can view this on both our Facebook page and our Her library. So that's uniteforher.org/Her library. And of course, we could not bring our regular digital education events without the huge support of our sponsors. So I do want to start off by just giving a big thanks to our 2023 education sponsors. Presenting sponsor for today is West Pharmaceutical, but we also have additional support from Daiichi Sankyo, Lilly, and Merck, and they really allow us to continue to bring the best in the industry with important topics for our Unite for Her members. So before we get started, I also want to plug, because we've got a lot of virtual events coming up that I want to make sure everyone is well aware of. So February is a busy month for us. So we will be kicking off February with our virtual hangout as we normally do. So next Wednesday, our virtual hangout, we will be joined by our sexual health counselor, Sabitha, and she will be talking about dating and cancer. So we know that this is a difficult world to maneuver for a lot of our members. So she'll be diving in, giving some suggestions, asking your questions on how we can walk through what that's like for anyone, whether you're single, whether you are post a relationship. She's got great advice for you. In addition, we've got two really wonderful speaker series happening. We've got on February 2nd, we will be talking all about courting. So we have a surgeon and a physical therapist joining us talking about courting and then why it happens and what can be done about it. And then we're also featuring our Black History Month for the month of February. So we will be talking with a few of our integrative providers about the services they offer and how that can be helpful, because we love always, hearing more from our providers, especially our providers of color. So how they connect with our community. So be sure to pop on for all of those. As always, we'll be promoting them on our social media and in our newsletter. So please be on the lookout. Okay, let's hop on in to our topic for today. So for today's Ask the Experts, we've got two incredible guests from MacroGenics. They're answering your questions about immunotherapy and how that works along with your immune system to destroy cancer cells. So a lot of learning to be had, a lot of great questions about this topic. So I want to introduce my two guests for today. So first, Amber Svardal is currently the medical science liaison for MacroGenics. She focuses on breast cancer treatments and provides clinical support on disease state, side effect management, on-label data, clinical trial results, and more. She is an oncology nurse with a background and a master's degree in nursing. She's got more than 10 years of clinical experience as an oncology nurse, and her focus is on radiation oncology and pediatric oncology. In addition, we have joining us today, Sasha Stanton. She has received her MD and PhD from the Albert Einstein College of Medicine in New York. She completed her residency in internal medicine at New York Hospital Weill Cornell Medical Center and her hematology oncology fellowship at the University of Washington Fred Hutchinson Cancer Research Center. She then completed an immunology postdoctoral fellowship at the University of Washington Cancer Vaccine Institute. Her research focuses on antigen discovery and vaccine design for breast and head and neck squamous cell cancer prevention vaccines. Pretty cool stuff. She's also interested in immune modification and the tumor immune environment in breast cancer. So, truly, both experts in their fields joining us today. So, please join me as I welcome Dr. Stanton and Amber. Thank you so much for your time today.
Thank you for having us.
Thank you.
Oh, we appreciate it. So let's dive right in, because I know immunotherapy, immune system is a subject that many of our members have questions of. So Amber, maybe you can start us off by just sort of sharing a little bit about what actually is immunotherapy, and then what is the role of our immune system together with that?
So immunotherapy is a targeted treatment. As you're all aware, chemotherapy is what kills our cancer cells, but it can also kill healthy cells as well. So immunotherapy is very targeted therapy. It's used to engage and restore one's own immune system and attack the cancer cells. It can be used in combination with traditional therapies such as chemotherapies. And there are a couple different types of immunotherapies, including monoclonal antibodies, immune checkpoint inhibitors, and cancer vaccines. So that's an overview, just a brief overview of immunotherapy itself. So targeted therapy. Mm-hmm. So just to start off with a little more general, like what is the role of our immune system? Because we'll kind of dive into how all of these play out together as we go through the talk a little bit more. But what's the role of our immune system? So our immune system is like an army of cells that attack any foreign invaders or cells that our body recognizes that aren't their own, such as cancer cells. So it's made up of various cells and tissues throughout the body. It also, along with killing foreign invaders, helps maintain the balance of our cells throughout our body, known as homeostasis. And then the other thing I wanted to say briefly too is immunity itself. Our own immunity is our own immune system's ability to kill off these foreign invaders. And sometimes when we don't have, when we've gotten a lot of chemotherapy or a lot of treatment for cancers, or have a large tumor burden, meaning a lot of cancer throughout our body, our immunity isn't as strong as it once was. And that's kind of how they'll tie together. But we'll dive more into that here shortly.
Yeah, thank you for that explanation. And I guess I know, when we think of immunity, there's actually varying types of immunity. It's not just like one road that this is your immune system. Dr. Stanton, do you want to explain a little bit about the different types of immunity that we have?
So, and we've all really experienced this in our lives. We have two big, broad types of immunity. We have innate immunity. Immune systems, we always end up describing like the military. I think of the innate immune system like the Marines. They're first on the beach. They're really the ones that when you think about like scratching your hand and you get red along where you've scratched your hand really quickly, that's the innate immune system. That's them trying to amplify and bring up an immune response. The adaptive immune system, and we've all become experts on this with the COVID vaccines, is a much more Navy SEALs, very highly specific, very targeted attack of infections. And really what started identifying the adaptive immune system and really identified vaccines was in smallpox. Even in the 1600s, they were realizing that all sorts of people were getting smallpox, but a particular type of people, basically milkmaids, wouldn't get smallpox. And the whole point of this was your adaptive immune system, and those are going to be B and T cells. We'll talk about that coming up. We're able saw a similar kind of virus, cowpox, and therefore gave them immunity, kept them from getting smallpox. So that was really the beginning of when we understood the immune system and really the two different big broad types of immunity.
Interesting.
Did that help?
Yeah, that definitely did. And you pinpointed two things, those B and T cells, which I know is something that we often hear, right? T cell, like your T cell killers or your B cells. But I know there's a lot of confusion about what exactly does that mean? What exactly do they do as part of the adaptive immune system? Can you go in a little bit about that?
So your B cells make antibodies. They're the cells that make antibodies. We actually can now make antibodies in the lab, and you have heard of Keytruda and pembrolizumab, which is pembrolizumab, and Herceptin, which is trastuzumab, and Perjeta, which is pertuzumab. All of these are anything that has mab at the end are monoclonal antibodies. We scientists are not that.
Well, now we know. I love that. That's a good reminder, though.
That's how when you look at the name and you see mab, you're like, oh, this is an antibody. So B cells make antibodies, and these antibodies are very specific. They recognize a very small part of a bigger protein, the HER2 protein, the PD-1 protein, and they're able to use that to then amplify, again, recruit the immune response. T cells, there are many flavors of T cells, but T cells are very specific. There are killer T cells or CD8 T cells that, again, recognize a very specific part of the protein, particularly in a context, we call it MHC context. And that are able to see that and kill that particular cell. And so you'll hear about killer T cells or helper T cells. Helper T cells work with the innate immune system that's kind of showing the T cells what they need to respond to, and helping those killer cells develop an appropriate response. So the B cells and T cells do very different effects, but really what they're doing is very specifically attacking either a virus, a bacteria, or an abnormal cancer cell that's developing in your body.
Okay. So just thinking a question myself, immunotherapy, does that work to support one particular type of like a B cell or a T cell, or does that work to support both of them? I'm just curious.
Well, immunotherapy is a huge, sorry, was this yours, Amber?
No, this was mine.
Immunotherapy is a huge umbrella, and we have multiple types of immunotherapy. Okay. So some people may see things like CAR T cells. Those are actually T cells made in the laboratory that are given back to you, or adoptive T cells.
Okay.
You may get monoclonal antibody, Herceptin, Perjeta, Keytruda. Those are all antibodies that are given to you. So they're not your antibodies, they're made outside and given to you. But there are also things like cytokines. IL-2 is one. Actually, interestingly, anybody who's gotten Neulasta, GM-CSF, is a cytokine. It's a chemical that tells your immune system what to do. Neulasta tells your immune system, release more neutrophils because you're getting chemo that's bringing down your natural defenses, and that's not safe. So, there are many, many different types of immune therapy that we use, and that is standard therapy or therapy that's more of a trial that are more tested.
Okay. Thank you for that clarification. Now, there's something else when we think of immune system, and this word was really thrown around even when we were learning about COVID and the COVID vaccine, is antigen. So what is antigen, and how does that play a role in immunity and our immune system? Amber, can you help us with that?
Yes. So an antigen is basically just a foreign substance or a toxin. It's a protein, but these foreign substances or toxins are what trigger an immune response. And different things can trigger this. It could be bacteria or viruses. It could also be if you have an organ transplant. So that's why people are on medications for that. And then it could also be an autoimmune disease where your body recognizes that as not its own cells, as something different. So it starts to attack your body's own cells. And that happens in cancer cells too, where the body recognizes this foreign invader, this antigen, and wants to attack it.
Okay. So in terms of cancer cells and turning on and off the immunity or stop and go, how do cancer cells fall into this category and into this discussion? Dr. Stanton, do you want to explain a little bit?
So your cancer cells are you, right? And so that is really what we're trying to figure out. We want to figure out why your immune system, some people's immune system sees the cancer cells and gets very activated for it. But your body has natural breaks for that because your body doesn't want your immune system to attack you. Your body, that is what happens with autoimmunity and with some people who have thought sometimes they can attack your thyroid. Sometimes they can attack your pancreas. That's type 1 diabetes. Sometimes they can attack your brain. That's MS. Those are all autoimmune diseases, and your body really wants to prevent that. And it does that through a series of signals that it sends to the immune system saying, don't come here. So we talked about Keytruda, is a PD-1 inhibitor. The other medications that are similar are PD-L1 inhibitors. And what those are the brakes of your immune system. Your tumor will have something called a PD-L1 receptor that basically, if it is present, any of these killer cytotoxic T cells that are seeing your tumor and saying, this is not normal, I should be killing this, are told to stop. I basically think of it like the brakes on a car. They basically, if the PD-1 receptor on the T cell sees that PD-L1 receptor in the tumor, it tells the T cell, don't work, stop working, nothing to see here, move along. And what Keytruda does is Keytruda blocks one part of that receptor. It keeps the and I probably should say pembrolizumab just because Keytruda is a brand name. Sorry, but Keytruda blocks the T cell part of that brake and takes the brakes off those T cells. So now those T cells are able to attack at will.
Okay. And every type of, every cancer cell has those stop and go signals. Is that correct?
Absolutely. And there are a ton of them. So
okay.
If you ever see, if you're ever an advocate seeing a science presentation, you're going to hear all sorts of stop and go signals. And we have some that we don't really know how to target yet, or we're targeting in clinical trials. And then some like PD-1, PD-L1, CTLA4. These are all stop and go signals that we actually do target in established therapy for cancers.
Okay. And is part of when someone has a cancer diagnosis initially, is part of that initial diagnosis process learning which type of receptors are on that cell? Is that something that happens for every patient? I would imagine yes, but I'm
absolutely. Not sure. So in the case of pembrolizumab, it really depends on what stage of cancer you have. So we have our metastatic patients, and for those patients, particularly metastatic triple negative, we actually check to see if they have PD-L1 expression. And if they do, those are typically the patients that we offer to give Keytruda plus a chemotherapy to.
Okay.
In our earlier patients, so you may also have your doctor talk to you about Keytruda in the neoadjuvant setting. So getting it prior to surgery, again, triple negative patients.
Okay.
And that is part of the Keynote 522 study that came out actually pretty recently. It's not been, we haven't had this as FDA approved for a while. And again, those patients, we don't actually look at PD-L1 inhibitors for. We will treat patients regardless of that. And really a lot of that is based on the clinical trial and how the clinical trial was run, and therefore how we got FDA approval for things. PD-L1 PD-L1 as a marker is not the best marker. It's the best we have right now.
Okay.
But we continue. There is active research to try to figure out better ways to pick the people who are this is gonna respond to. Because unfortunately, we're still not, and particularly in breast cancer, we're still not at a place where we can find immune therapy that works for every subtype, every type of breast cancer. We're still really working on that.
Okay. Okay. Thank you for that. And again, for those that have hopped on, I just want to remind we are here with our experts from MacroGenics talking about immunotherapy and how it works alongside our immune system with a cancer diagnosis. So doing a lot of learning today. Going back a little bit to the discussion that we had about antibodies, and we heard a little bit, you've mentioned monoclonal quite a bit. Are there, can we maybe revisit it and explain a little bit more about these different types of antibodies, these different type of treatments, immunotherapy treatments that are available? What other categories are available to us?
So I think I'll speak to monoclonal antibodies themselves. And again, just to maybe define again, what are antibodies? Because I know this immune system stuff, it's kind of a lot to grab a hold of.
Yeah, I know. There's so much, which makes it so amazing.
It is. It is. So antibodies themselves are produced by our immune system to respond to these foreign invaders or these cancer cells. They do this by engaging the immune system and attaching to those antigens or those toxins. They are in the shape of a Y. And the top of the Y part, at the top of the Y of the antibody is what binds to those antigens or those foreign cells or those cancer cells. So with monoclonal antibodies, so antibodies are they're a little more generalized. They're first on the scene there to start an immune response. Monoclonal antibodies are specific towards a specific antigen. For example, with these monoclonal antibodies, for example, in HER2 positive breast cancer, you have specific monoclonal antibodies that attach to and attack those HER2 positive tumor cells.
Okay.
So they are specific to an antigen or a toxin. They bind, the top of that Y on the monoclonal antibody is what binds directly to the tumor cell. And that binding in and of itself can lead to cell death. However, to just dive a little bit more, this also starts the process for ADCC, or antibody-dependent cellular cytotoxicity. Okay. And how these play a role. I didn't jump ahead, did I, Erin?
No, you're good. You're good. We're with you. We love learning the science, so go for it.
So that monoclonal antibody specific to that antigen or specific to that tumor antigen expressed on the tumor cell, HER2 positive, for example, the top of that Y for that monoclonal antibody binds directly to the tumor. With that binding, it also starts to draw in and attract some of our other immune cells or effector cells, such as macrophages and natural killer cells. So those cells of our immune system attach to the tail of the Y. So visualizing, you have that tumor cell, that Y-shaped monoclonal antibody. The top of the Y attaches directly to the tumor cell. And then those other immune cells that help kill foreign invaders or cancer cells attach to the tail. That binding creates a connection between the tumor cell itself and that immune cell. And chemicals are released that break into the tumor cell wall and then further break down. Once they get inside, those chemicals further break down that tumor cell and destroy it. And then you have just particles that float away.
Oh, wow. So there's, it's really interesting that you call out how, there are multiple levels of protection and destruction that go into this, and how things like monoclonal antibodies are signals for our natural methods of immunity and fighting disease, and how that sort of instigates that process as well. And I guess, that really speaks to how the two work so well together.
Yes, yes. Especially after, like I said earlier, somebody's had a lot of treatment. These monoclonal antibodies can help ramp up our immune system to get these cancer cells. They need a little help sometimes.
Yeah. So that's a good way to kind of get that going again. Is that what you're saying?
Yes.
Oh, interesting. Okay. So you talked a little bit about the adaptive and the types of cells with that avenue of our immune system. Getting back into the innate immunity, things that we naturally have. What types of cells in the body, like you said, first on the scene, we get a cut, it gets red. What types of cells tend to show up in that sort of situation with that sort of immune response?
So again, if anyone has had chemotherapy and needed Neulasta, you will know neutrophils because you live and die by them. So,
that is a word we know. Yes.
I'm sorry. Your treatment, you don't get treatment because your neutrophils are too low. That is an example of the innate immune system. Okay. Innate immune cells, they're not very specific. They don't recognize an antigen that Amber had been talking about. Mm-hmm. Instead, they tend to recognize stress signals, and that's what they work for. You get a paper cut. Well, your neutrophils are going to be the ones that are first on the scene, and what they have in them is they have all of these chemicals that bring in other innate cells. So basically, they call in everybody else. Macrophages, mm-hmm. Which anything that says phage basically means eat me. So basically what macrophages do, and dendritic cells can do this too, but they don't have phage in their name, is that they can eat up little pieces of the toxin, whatever toxin that may be, the bacteria you get in with a splinter, a cancer cell that has died and is now sitting around looking, the pieces of it are everywhere. Mm-hmm. They can eat that up, and then they can present that to a T cell, to the adaptive immune system, and basically talk to the adaptive immune system and tell it what to do. They can tell it to this naive T cell that's just hanging out typically in a lymph node. They can tell it, be activating T cell that mm-hmm. is going to kill the tumor, or be a helper T cell that's going to bring in more T cells and get more of a specific immune response. Mm-hmm. Or we also have policeman T cells, regulatory T cells. These are T cells that say, whoa, too much inflammation. We're going to damp everything down. And those tend to be cells that support tumor growth because they inhibit the immune system. So your innate immune system is almost the translator. It basically sees what's going on, gets everybody involved, and starts bringing that adaptive response in. It's also, and again, why we can't treat people whose neutrophils are low. It's very important for that first on the beach protection. It can kill bacteria. It can get your fever up so that you have an infection and your immune system is getting active. And that's really why with chemo, when we're worried if your neutrophils are low, if you're neutropenic, you need to go right to the emergency room. You need to get antibiotics. Your immune system is missing that first step, that first innate step of bringing in the troops, really getting a good immune system. And so we have to help you with antibiotics and watching you closely for infection.
Oh. That is wonderful, because I know also, one of the things that I hear so often is just that, Dr. Stanton, I had to delay my treatment. My neutrophils were too low. So just sort of understanding why that delay has to happen and why that's so important, I think provides a lot of clarity for anyone that's been in that situation to sort of understand why it's so important that those numbers are up within normal limits.
We have to be safe because we have bacteria everywhere. And some of it is very important. We have bacteria in our gut that tells us that's healthy bacteria that we have to digest things and to properly process food. But when your immune system isn't good enough, that bacteria can get into your bloodstream and be very dangerous. So even healthy things, normal things, if you're it's just not safe if it's too low. And we have that is why I always explain to patients when I'm giving chemo, we always dose you based on height and weight, but no person is exactly what, you're not just a mass, you're an individual. And so you may not respond the same way. And that's where we have to hold a dose, lower the dose. It's not a failure. It's you're an individual and we have to individually tailor this for you.
Yep. Yeah, that's a great explanation. And something else that you brought up in that last response, Dr. Stanton, is really just calling out how innate and our adaptive immune system work together. I mean, I think that example, Amber, that you mentioned with the Y of how, it calls in other types of cells was a wonderful explanation. Are there more ways in which the two work together that would be good for us to understand?
Absolutely. So Amber was talking about that Y, and that piece of the Y, we call it the FC portion. The Y part, these two parts of the Y are the antigen specific. Those are what recognize a specific area of that antibody. And then there's this arm down at the bottom. This is the FC. And that is what cells like natural killer T cells, which are actually part of the innate immune system. They are not specific for antigen. They're specific for recognizing if you have a cell that's surrounded by antibodies, your immune system sees that as this is a danger. This is a cell that shouldn't be here. And these natural killer cells can also come in and take out that cell.
Okay.
And that's a very important part of the innate immune system for treatment with Herceptin and Perjeta. We can see that these natural killer NKT cells or NK cells are very important for having that for getting immune response. Even when you have a HER2 positive breast cancer, you don't think you're getting an immune therapy. Herceptin and Perjeta are immunotherapies. They're very effective, and their immune part is necessary. Amber has a medication called Margenza or margetuximab, which is yet another type of HER2 therapy that specifically recognizes that FC portion, that arm portion of the antibody, and actually is more tuned to that FC portion. So basically, they took those HER2 antibodies and modified them to try to enhance the immune response. So there's a lot and there's a lot we don't understand, and there's a lot we're still learning about.
Yeah.
But absolutely, we need the combination of the innate and the adaptive and how they interact together. And then another part of that is the antigen presenting cells. Those are all part of the innate immune system. Those are all cells that eat things, macrophages, dendritic cells, even B cells can be antigen presenting cells. So those are the ones that make the antibodies. They'll take up pieces of protein, antigens, and they put them in a specific context, a specific lock and key context. So your T cells aren't just going to attack anything that is present at where that antigen is. They need to see it in self, in your own body's context. I like to describe it as everybody gets, when you're getting red blood cells, you have A, B, O, you have your red blood cell type. Well, you similarly have a white blood cell type. And so your white blood cell type is based on your MHC class 1 and class 2. And those are the context that you have to show that antigen in these antigen presenting cells for those T cells to be activated.
Wow.
That was confused everybody.
It's very specific. It's a very specific. You have to have a specific antigen for that T cell to come out and attack it.
It's a very, very, very specific combination of things that happen to get a T cell to work. They have to
Yeah.
be very, and it's to protect you from an allergic reaction, an autoimmune response where you would attack other parts of your own body.
Okay. Well, and again, I think it just speaks to the complicated nature that is our immune system, but also how incredibly amazing it is, and how our body really does try to work on its own to keep us healthy, but with the support of amazing treatments and continued research and clinical trials like what you're doing, Dr. Stanton, and new medications, Amber, like what you have, continue to bring us forward and provide even more specific treatments to really continue to improve a person's wellness, their longevity, quality of life, overall prognosis. There's so many good things about it, but it's complicated. There's a lot that goes into it. My gosh. Well, we had a couple questions that came in from our members ahead of time, which I think are just really great questions when we think of immunotherapy in general. So we had one question that was from someone that just asked, how do you know if you're living with metastatic breast cancer? How do you know if you're a candidate for immunotherapy? Is everyone a candidate for immunotherapy? Dr. Stanton, could you dive into that?
Unfortunately, they are not yet. So definitely talk to your doctor. If we have ongoing clinical trials in many of the subtypes, in many of the different types of breast cancer. So when I say subtypes, I'm talking estrogen hormone receptor positive, HER2 negative, HER2 positive, triple negative. Those are sort of the big catchment carry questions. Triple negative, again, in metastatic disease, if you are PD-L1 positive, we have a known FDA therapy. Now, there are many clinical trials, many trials that we're running. I work for the Earl Childs in Portland, many trials that are being run all around the country, looking for other ways to treat not just triple negative breast cancer. So clinical trials is really the one we're really struggling with is hormone receptor positive, HER2 negative breast cancer, because the hormones, those estrogen and progesterone that's really being used to drive those tumors tend to immunosuppress the tumors. The immune system doesn't see those as well as it tends to see those triple negative tumors. And it may be a relation that they don't grow quite as fast, or they're not quite as aggressive. But there are many studies in all stages of breast cancer where we're trying to figure out how to get the immune system to work better with those. So really talk to your doctor, ask them if they know of clinical trials. It's a little bit of a clunky system, but there is clinicaltrials.gov. That is all clinical trials in the country and in the world. I mean, they have clinical trials all over. And that's a great resource. It's anything funded by the NIH is funded by us in America, and you have every right to look at that and see if there are trials that will help you. And then I know I get emailed by patients saying, do you have a trial? Is something available? And I know a lot of my colleagues, and we're also always happy to see if we can find something as well. So there are, first step is talk to your doctor, make sure that they can look into it. And then the next step would be the broader community and seeing through clinicaltrials.gov, seeing if there's something in a center near you.
I love that. And I'm glad that you shared the clinicaltrials.gov. I know we've shared that before in other talks that we've given just about clinical trials in general, because they are so important, and understanding that, everyone has access to potentially be part of a trial. So it's always good to ask and do a little research for sure.
And just to tail off that, there's a lot of patient advocacy groups in breast cancer that on their websites really lay out the current trials in easier to understand language, because even I struggle sometimes navigating that site, and I look at it a lot. So I think, so that those are other resources out there too.
I love that.
It's clunky, but there's Komen, there's there's NBCC, there's lobular breast cancer, there's inflammatory breast cancer. The advocates are fabulous. We're really proud of our breast cancer advocates. This is not every specialty that has advocacy groups like this. So when I talk about, oh yeah, I go to grant reviews and I have an advocate with me, all of my head and neck people are like, say what? And I'm like, oh, you haven't met breast cancer. We're the best group.
Yeah, that and you bring and right, we need advocates like that because Amber, like you said, it's confusing. The words we are not familiar with. We didn't all go to medical school to understand, but so it's really important to get that clarity. Like, yes, am I a candidate for this? How can I understand? Even just filling out the paperwork, having someone that you can lean into that can help you along to make sure that's completed if you are in that process. So you're right. It's a pretty amazing space to be in with all of those different advocate persons and organizations. Wonderful. Okay. Another question that came in, which again, great question. Is there an advantage to immunotherapy over other medications? This particular person called out letrozole, but we could think of this in the context of other medications. So what is your response to that when we look at how it compares to others?
Again, I think it would really, so in the letrozole case, no, because the immunotherapy and the letrozole are sort of different. They're targeting different things.
Okay.
That we know of now. So again, letrozole is an interesting one because our hormone receptor positive, HER2 negative patients are actually the patients that I like to focus on because I feel like we don't have enough immunotherapy for them right now. And I want to get them a similar targeted therapy as everything, as all of our other subtypes. Luckily for them, though, we do have a targeted therapy in that we know really what tends to drive the growth of those tumors until metastatic, when you can get these estrogen mutations, is hormone signaling and estrogen and progesterone signaling. And so the letrozole is essential for that. That is something that we have definitely shown in randomized controlled trials to prolong people's lives. And that's been shown for decades. It is not an easy drug. And I know it is a toxic drug, but it's not something that you can sort of not do and do immunotherapy typically. Again, talk to your doctor, but I do know my mother had breast cancer, and I think she almost disowned me being on an aromatase inhibitor. So I recognize both as a daughter and as a physician that they are not easy drugs to tolerate.
Yeah. We hear that, but we understand.
But they're not
what they're supposed to do.
They do what they're supposed to do.
Yeah. We had one comment that I guess we hadn't touched on, and maybe we can briefly wrap up with this just in terms of side effects. One of our members had one dose of Keytruda, sounds like had a pretty difficult side effect, less than 1% of patients that have this response. I guess, can we briefly just talk a little bit about potential side effects that may come along with immunotherapy? I think that's good for any of our Unite for Her members just to be aware of, as I'm sure this is part of the conversation with their medical team, but just as an awareness.
Absolutely. So immunotherapy, very beneficial, but also has very unique side effects. So unlike the side effects we're used to seeing with chemotherapy, immunotherapy, a lot of the side effects are the thyroid. I've seen it quite a bit. I like to describe it as the itises. Anything that's an itis is an inflammation. Pneumonitis, inflammation of your lungs. Gastritis, diarrhea, which is inflammation of your gut. Hypophysitis, which is inflammation of your hypothalamus.
Okay.
Things like adrenal insufficiency, you can have hypothyroidism, so an attack on your thyroid gland. All of those can be seen. So Keytruda, with these drugs, we're giving them intravenously. And so we're taking the brakes off of T cells, not just in the tumor, but throughout your body. And so you can absolutely see these side effects. Some of them are not reversible, like the thyroid. You have to go on to thyroid medication. But we are getting much better at recognizing that. Your doctor, when they put you on these immune checkpoint inhibitors, will be checking your thyroid and watching very closely for that. There is a new medication that's been sort of all the rage, and HER2, that is
Yes.
an antibody hooked up to a chemotherapy. And so you're getting, we call it an ADC, antibody drug conjugate. And so basically what you're doing is you're getting that antibody is specific. Remember, it's going to take it right to the tumor, and then you're going to release the drug. And HER2, one of its big side effects is pneumonitis, inflammation of the lung. And so we as doctors are really understanding now that and HER2 is famtrastuzumab deruxtecan. It's a very long.
Say that 3 times fast, Dr. Stanton.
And so we are getting very used to seeing interstitial lung disease and pneumonitis. And so if you're short of breath, if you're noticing, I used to be able to climb the stairs and now I'm not. In some of the trials that were just presented at San Antonio, they were talking about even doing CT scans every 6 weeks to try to catch that early. And you stop the drug. In the case of Keytruda, they'll give you steroids sometimes if you're having a lot of diarrhea. Rash is another one. That's pruritus, right? Inflammation of the skin and itching. So any of these are newly done for our immune therapies. And we really do have to watch for them and be careful with them. So.
Okay. And I guess as with all of the positives that come from this kind of treatment, of course, there's potential for side effects. And the best thing anyone can do is just communicate with their medical team. Be aware if things change. I always say I am an over communicator. So if you have questions, tell your team, let your physician know from the very start. Over communicating is always a good thing. And then it gives you a little peace of mind. That maybe, it's nothing that you have to worry about, but at least sharing and being aware.
And you are never bothering your team, ever. That is, I tell all of my patients, this is the number, you call it 24 hours a day, 7 days a week. You wake us up at night, that's fine. That's what we're there for, just sometimes it may be nothing to worry about, but we want to know because we're getting much better at recognizing early danger signs, which particularly in immunotherapy. Particularly in clinical trials. We run a lot of clinical trials through the Earl Childs, and a lot of them involve some scarier side effects. And so if I'm having patients that are admitted to the hospital getting CAR T-cell therapy and they're getting high fevers or they're getting confused, those are all things that trigger in me, okay, I need to get steroids on this person. I need to do whatever I need to do. And that is not bothering us. That is really making sure that we're on top of things.
Good to know. Yep. One final question that just came in the chat, and then we will wrap up. Is Zejula also associated with pleural effusion as a possible side effect? Are you able to answer that?
What is Zejula? I may not know that brand name.
Okay. In which case, as we always
Google it.
That's okay. And while you're doing that, as always, if we're not able to answer this here, please be sure that.
Okay, there we go.
You're asking your team. Okay.
Trials with niraparib. I didn't actually
know the brand name.
The brand name now. I don't know why I didn't know that. I typically with niraparib, the things I see are diarrhea. That's the biggest side effect I know. Pleural effusions are rare, but they're not never seen. Often what they want to do with that though is they want to see what's going on with that what's causing that pleural effusion, because there are many different causes of pleural effusions.
Okay.
Thank you
Wonderful.
for that. Sorry, I don't know.
No, oh my
All
gosh.
of the brand and
There's a lot of medication. I mean, and you know, we can totally understand. So we know we appreciate you doing a quick Google and answering. And as always, you know, again, ask your physician, communicate if you have that question, if you feel like that's something you may be experiencing. You know, over communicating. As Dr. Stanton said, never bothering, always good just to ask, and then you can feel reassured for sure. Wonderful. Well, as we wrap up today, any final thoughts that you want to share with our members about immunotherapy, their immune system? Any sort of takeaway that either one of you just want to pass along before we conclude our Ask the Experts today?
I just want to say thank you, everybody, for attending today. It's been a pleasure being here. As a former nurse, it's kind of nice to have some kind of patient interaction on a compliant HIPAA level. But there's still a lot more to learn with immunotherapy. And I agree. If you're not sure if a symptom you're having is something you should be worried about, I would always tell my patients, call. Like, I want you to call for whatever issue you think you're having, because I'd rather be the one to worry about it than you. Because otherwise you're sitting at home worried, is this good or bad? Or, you know, and I'm an overthinker. So that can be tough if you're that way too. So never hesitate to reach out to your team. And again, thank you for being here with us today.
Absolutely. Thank you. And you know, I know we are not quite there yet, but we are really working. There are a lot of really amazing people doing really amazing work throughout the breast cancer and even pre-cancer spectrum. And so absolutely advocacy and clinical trials, if they're available and you're eligible and you're interested, and you know, all of it really does help us, and just keeping that communication open with your team is essential. So thanks so much. I will talk immunology.
Well, we will have to have you back for sure. And we appreciate the work that both of you do to keep this part of treatment moving forward and to keep bringing, you know, new information to those with breast cancer, and hopefully just continue to see improvements in longevity, like we said. So we appreciate all of the hard work that you are doing on the back end, because I know our members are so grateful for all of you. So thank you so much.
Thank you.
Thank you.
You're welcome. All right. As we wrap up today, we had a great discussion. I know we shared a lot of information about the immune system. So please know that if you want to come back and rewatch this again, it will live on our Unite for Her Facebook page, as well as our Her Library, which you can access at uniteforher.org/Her Library. And we welcome you to come back in and give a re-listen, because as we've learned, the immune system is complex, but it is amazing. With that, just a quick reminder as well that we've got some really exciting virtual events also coming up for you. So we will be kicking off February with our virtual hangout next Wednesday, the 1st at 5 p.m., talking about dating and cancer. We know that this is a unique space to be in for some of our members, and difficult conversation. So let us help you navigate that. In addition, we've got some speaker series coming up next Thursday, September 2nd. We're talking about courting, why it happens, what you can do about it. And then the following week, we are featuring for February Black History Month, a few of our providers of color, and talking about these wonderful integrative therapies that they provide. So lots of great stuff coming up. Please be sure you be on the lookout on our social media, in our newsletter, to join us for all of these. And we want to thank you again for joining us for our Ask the Experts today. Thank you so much to our sponsors, West Pharmaceutical, as well as our supporting sponsors, Daiichi Sankyo, Lilly, and Merck. And of course, we will see you all again very soon. Stay safe.